special Professor Rasha Kamel and all the team, Professor Merit Al-Maadawi and Professor Iman Awais. I'm really honored to be in this session with the eminent Professor Ashraf Salim and Professor Dorea Salem, who are the pioneers in the breast imaging in Egypt. And now we open the discussion for the attendee for any question for Dr. Tabar. Iman, you will manage the questions.
Thank you, Dr. Sahar. Thank you, Dr. Tabar, again. We have very interesting questions. For the first lecture, breast cancer screening controversies, we have two questions. The first question from Dr. Rasha. What is your opinion in countries with high population that have changed their screening programs from mammography screening to clinical examination in addition to the imaging, plus or minus the imaging? Do you think this is a better solution for them if they cannot afford mammography for all the female population?
Yeah, it's a very interesting question. You know, I would then compare the situation to that of the HIP study. Namely, yes, palpation can provide the benefit of downward stage shifting. You replace the stage 4 with a palpable stage 2. It's earlier, it's going to decrease mortality. But of course, the ideal is to replace the stage 2 with a stage 1 or stage 0. So wherever you can apply mammography, or why don't you think about using a much cheaper method, which I would very much like to have introduced all over the world, the multimodality approach. If you cannot afford mammography, complex, and so on and so on, there is the automated breast ultrasound. And you know, in the Middle East, as far as I know, the frequency of breast cancer is much higher in younger women who have dense breast. I mean, we were together in Jordan, and we saw that 80% of the cancers were under 50. So this would be my suggestion. Just keep in mind, decision makers and physicians, steal time from cancer. If you are poor, you cannot afford ultrasound, you cannot afford mammography, perform physical examination. Is it going to be effective? Well, if it was effective in New York, it can be effective anywhere. But the ideal is to steal as much time for breast cancer as you ever can. And that's where the machines come for help, mammography or ultrasound. Even if countries that can afford mammography should introduce multimodality screening. It's not fair to give a very reliable mammography report to a woman who has fatty replaced breast while we are cheating on the women with dense breast. We know that every third invasive cancer hiding in the dense breast tissue, we are going to miss. That's not fair.
Okay, Dr. Tabar, I would like to add a few points about what you just mentioned. And because the question that the Professor Rasha just said about is concerning the Egyptian new early detection of breast cancer. And as you remember, we started the screening mammography since the year of 2007. And we did some good job at that time, but after the revolution and things got worse in Egypt, now we carefully examined and scrutinized the number of mammography units that are spread out throughout Egypt, as well as the number of trained radiologists who can do that. So we reached the idea, the theory, is that we will combine clinical breast examination for all women starting from the age of 35 onwards. And based on this clinical examination, if the clinical examination are positive, these were due mammogram. And this as a short interval for 3 to 5 years till we can get more mammography units and train more radiologists throughout Egypt, and then where we can begin the second phase of the study. And I'm sure it would be the screening by its proper sense. As you said, this is the most logical and this is the most accurate, and that's what we really look forward to achieve in Egypt.
I can only congratulate to all your efforts. Those colleagues, yourself, and many of those I know have their heart in the right place. But as you see, you heard in my lecture, for 5,000 years, nothing happened. And in countries like Sweden, and not too many more, you know, we could change everything in one generation. Probably in your place, for God's sake, you have 100 million people and more. So it's going to take a longer time, but you are doing the right thing. You are not going to let this issue go. You do your very best, taking the circumstances into account. And I'd like you to collect data. This has always been our strength. Collect data, describe what you did, describe the impact of it, so other countries in similar situations like yours can learn from it. What's the benefit of it, right? So I'm very positive to hear whatever you're doing, but data, publications, please, right? It's so important.
Sure.
Thank you. Thank you, Dr. Tabar. Thank you, Dr. Ashraf, for this informative and practical explanation. Our next question it was actually repeated many times. We have from Dr. Rasha and Dr. Arwa and others about the higher incidence in younger population below 40. Do you have similar scenarios, or can you suggest what contributes to this risk factors in this young population, our population in the Middle East?
Absolutely not. It's not only the Middle East. If I have the globe in front of me, I can slice it about at the level of Middle East, Egypt, Jordan, and so on, and all Far East. I mean, in Singapore, China, Taiwan, same phenomenon. It's some kind of a magical trick by those who cause breast cancer. I don't know. It's just a fact, and we have to adopt our screening strategy to this. I don't like that. I've been, Ashraf, I've been in Jordan for 7 consecutive years. They were very kind. We had a great time, and they never listened to us. I mean, China goes very far to the end. They want to throw out mammography. They only want to use ultrasound. Now that's wrong too. You know what I mean? So I would really love to see this multimodality approach, namely bringing the women. Ultrasound is very easy to take. It's very easy to do. It's not harming women. You can do it, for example, alternating mammography in January and ultrasound in June, and then next January. You see what I mean? Or you do ultrasound and mammography January, and you do ultrasound only in June, because breast cancer grows much faster in younger women too. And it's not ionizing radiation, and it's not costly either. The automated breast ultrasound doesn't need the enormous skills of trained ultrasound specialists or technologists. I would make something wrong if I told you why do women in the Middle East or Far East have more dense breasts. That's it, c'est la vie. So let's adopt our method to it. use ultrasound much more often than you actually do.
Thank you, Dr. Tabar. We have also a very important question for you from our chairperson, Dr. Ashraf.
Okay, Dr. Tabar. There are many newly published data, retrospective studies and meta-analysis studies about the question that deals with, can breast cancer imaging features predict the molecular subtypes of breast cancer? And I quite remember maybe more than 10 years ago when you stated that the casting microcalcifications are much worse than in a cancer speculated lesion alone without calcification and with calcification, as well as the round, well circumscribed tumor that you call them. These are the killers. And now there are many studies that say that these round tumors are the killers because molecularly, these are the triple negative cancers, while the casting types of microcalcifications belong the HER2 positive cancers. I would like you to comment on these studies.
Right. You know, it's such an important issue because once again, there are researchers who are just moving between the two extremes, and they want to ignore all the previous first and second generation prognostic factors, rather go to the molecular picture. We published, our research group I was talking about, published quite recently a very nice article about the enormous strengths of the third generation biomarkers, namely the mammographic appearance. And it's not that complicated. So what researchers in the future at your place all over the world needs to do is to repeat what we have already published. You look at a mammogram and you don't even need to be a doctor. Anything that is long and white and Y-shaped, that's the casting type calcification. And then you can go to the laboratory. I guarantee you 92% of the cases are going to be HER2 positive. But you know what the problem is? As I showed it to you, the casting type calcifications may be associated with a small stellate lesion, and the pathologist determines the biomarkers from the stellate lesion, not from the killing cancer. That's a huge professional mistake. And then they doubt the value of mammographic appearance. Don't ever forget the basic rule. Mammography, ultrasound, MR, is imaging the underlying subgross pathology. And the cancer has the stellate shape or circular shape on histology and on mammography because the driving force, the genes, are different. So I look at a mammogram and I can tell you what the genetic constellation is. Be careful with the circular lesions that are a little bit unreliable because on the one hand, papillary cancer, mucinous cancer, is circular, always. And the devil, the triple negative basal-like, yesterday you called it medullary carcinoma, today you call it basal-like, is circular too. So there we have to make a distinction. And that distinction you might not be able to do by looking at a mammogram. So we are not throwing out the previous biomarkers. No, we are adding one more to it. The first generation biomarkers, tumor size, node status, histologic malignancy grade, is evergreen. But its value is decreasing with decreasing tumor size, right? Under 9 millimeter, it doesn't matter whether it's basal-like or mucinous, But with increasing tumor size, then they gain prognostic value. Then, because we were not satisfied with these three first-generation prognostic factors, the biomarkers the immunohistochemical biomarkers were worked out. I'd like to call your attention. Those fool you in the killing cancers. For example, the huge invasive cancer of mesenchymal origin or lobular cancer, always ER positive, PR positive, HER2 negative, and has a 1% proliferation index. It suggests that it's a good cancer, yeah, sure, but 40% die from it. So be careful with these new researchers who believe that their PhD is going to throw away everything we learned so far. No, you have to stand on my shoulder and grow from there. And that's real science. And philosophically, that's correct too, right? So
thank you so much.
Try to learn those very simple biomarkers that I described in very detail in my second lecture. Try to
Thank you so much. Yes, very interesting. And this is, of course, an expanding research topic. Of course, we will be able to communicate between the imaging finding and the subtypes more often in the future with advances in the artificial intelligence and the technical advances. We have a very good question from Dr. Sahar for the second lecture on the breast cancer origin do you think that the tumor biology may affect the duration of the interval screening? In other words, do luminal A cancer will differ from luminal B or HER2 or enriched triple negative in required screening interval by mammography, or all cancer are annually? I think she means post-treatment after the surgery. Do you think if the patient was diagnosed with triple negative, she required more frequent follow-up than the one diagnosed with luminal A breast cancers?
Now, you know, I could say it's a good question, but it's not a complete one, because you only talk about one biomarker. I mean, if it's a 10 millimeter or 9 millimeter unifocal carcinoma, I don't care whether it's HER2 positive or negative. And luminal A or luminal B, all these are a little bit artificial. If you look at this, the site of origin, all of them originate from the acini adenocarcinoma of the breast, right? So here comes early detection into the picture. If that cancer, any cancer originating from the acini are larger than 2 centimeters, which unfortunately happens, then you can bring in the HER2, the immunohistochemical biomarkers, molecular markers, and so on, as a help. But the larger the cancer, the less controllable it is. So here we go again. The snake bites its own tail. Early detection, and then you are not going to ask questions like this. Whenever you want to ask a question like this, why don't you tell me, and the mammogram looked like this? Do you understand? You should never in the future try to treat the patient or try to plan the management without telling me what the mammogram looked like. Because if it's a 14 millimeter stellate lesion, and you tell me it's HER2 positive, I don't believe it because it's not true. If it's a 10 millimeter circular lesion, I might believe it. Do you understand? Never just one or another. We brought in the third generation prognostic factor, the mammogram, but we don't throw away the others. So this way we are going to get a much more accurate picture of the individual case, and that's called precision medicine.
Thank you so much, Dr. Tabar.
Are we through? No more questions?
Thank you so much. We have just a very last question from Dr. Iman from the attendees. She's asking about, does the DAB invade the basement membrane? And if not, would it be named DCIS?
No. Please understand. Okay. Do you know what a saguaro cactus looks like?
Yes.
You know that, right? Arizona, right? Saguaro cactus, big one. You see, it's born like this. It has one trunk.
Yes.
And it turns 75 or 100 years. And it gets a sidearm.
Yes, it does.
You see? And every 15 years, it gets another sidearm. Now, what is this? That's an invasion, right? It invades the air. Now, imagine the following. Here is the milk duct, and here is the basement membrane. Yes, indeed, the stem cells drill themselves through the basement membrane. By the time I see it, it's too late, right? That's why it's palpable. That's why there are many. I have 5 fingers, and there will be new ducts. That's 10 fingers, right? And the additional finger, that's invasion. That drills itself into the surrounding. If the colleague who asked this question wants to have immunohistochemical proof, then please turn to tenosyne staining. Tenosyne, T-E-N-A-S-C-I-N, tenosyne staining. Whenever cells drill themselves to the surrounding tissue, benign or malignant, tenosyne is formed. In all DAB cases, there is overexpression of tenosyne. But likewise, gynecology, when the fertilized egg arrives to the uterus, it wants to stay there. And it drills anchors, right? It's full of tenosyne. Do you understand?
Yes. Yes, thank you so much.
There is a new duct, and that's invasion. Pathologists really have to grow into the 21st century. Forget about the term DCIS, because if the cancer grows in the acini, it's cancer in situ, but not ductal. If it grows in the duct, that's ductal, but it's invasive. So there is no such disease as DCIS. That's a huge professional mistake. Do you understand?
Yes, I understand, and thank you.
Pathologists are guilty for this. We really have to bring them into the revolution that we created. Pathologists are guilty. They call a stellate lesion invasive ductal. For God's sake, it has never seen the ducts.
We got your back, Dr. Tabar. Don't you worry, and thank you for enriching our imagination for a better understanding of mammography. I will not stop learning from you. Thank you so much. We don't have any further questions.
Thank you very much, and I really appreciate your invitation. Love you guys. I wish you a very good conference.
Thank you so much. Now we announce the end of the first session. We will have a 5-minute break, and we will back to you for the second session. Dr. Sahar.
Thank you, Professor. Thank you, everyone, for the attendance. Thank you, Professor Tabar, and thank you, Iman, for the questions. Thank you all, and bye-bye.
Thank you.
Good afternoon. Welcome to our second session of the first day of the 13th PGICC conference. I am Shirihan Fakhri, the scientific moderator of this session. And it has always been an honor to participate in that great scientific